meet you, Alan. Hope you have a great chat, and I will pop back up in about an hour. 2 seconds, I'm just going to press the go live Facebook.
Thanks, Jeffrey.
Thanks, bye.
Bye, thank you. Are we live?
Yes.
Okay. Good afternoon, everybody. We have with us today Dr. Alan Bonder in the States, and he's going to answer some of your questions. Alan, there might be some people I know don't know who you are or connect, but tell them a bit about yourself.
All right. So first of all, good to see you again, Collette. Good morning here in the States. So I'm Alan Bonder. I am a hepatologist. I work at Beth Israel Deaconess Medical Center in Boston, and I've been taking care of PBC patients for quite some time. One of my mentors here in Boston was a PBCer, and then actually I got interested in it. So I've been doing this for quite some time right now. And I've been working with Collette, I would say 2 years now, Collette.
Yeah, I think so. Yeah, it's been great. It's absolutely fantastic. So do you work in a transplant center, Alan?
I do. I'm the medical director of liver transplant at Beth Israel in Boston. So that's one of my. I do take care of transplant patients.
And are you back doing transplants again now post-COVID?
Yes, actually. If there's actually a few interesting papers. The amount of organ donation during COVID time was the highest ever in the last I would say couple of years. Wow. And actually our center is going up in numbers. So yes, we are actually not slowing down. We're actually going up again. I think COVID has done a little bit change our patient profile. So we are getting a lot of young people with acute alcoholic hepatitis. So we are patients right now. So yes, we are busy, and then our numbers are up, fortunately for us.
Yeah, and you obviously are successful with donors then.
Yeah, I mean, so living donors we are starting up, but yes, I think this is the U.S. data, and again, it's so nice to see that despite COVID, we are seeing an increase of donors out there. So again, this is just so important for patients with liver disease. But as you know, there's a lot of people listed for liver transplant, and there's a lot of people who are not able to get a deceased donor. So another option is get a living donor.
Well, the living donor is quite an interesting one because I know they've been done here. And I also know they do split livers and things, but it really is an interesting side of transplant. And of course, in the old days when I first started all of this, there was more liver transplants in the UK for PBC than any other liver disease, but not so now because we've now got URSA, we've got Ocaliva and bezafibrates and phenofibrates and better treatment, better care and better monitoring, I suppose, really. So I think there's not as many now, and NAFLD and various things have kind of taken over, as you know. Okay, right. Well, I've got time at the end. We'll hear a bit more about that because it's nice to hear what other people do. So we're going to start with everybody out there. As I say, if you've got questions, fire them into Linda. She'll get them to me as soon as she can. And if we don't get to them all, but we usually do with Alan. Alan's pretty sharp and on the ball. But if we don't, we'll tie them over till next week. But we'll do all that we can. So our first question, so I take 500 milligrams times 2 of paracetamol when I'm in pain. Now, I don't think you call it paracetamol. You call it something else in the States.
I mean, Minofen, but it's the same thing.
Yeah. As I have PBC, is that too much to take? But what they don't say in here is in what time span. Because it's 1,000 milligrams, not a day, but in a 24-hour time span. Is that right?
Yeah, I mean, I think we are. So there, I would say there's a couple of things here, Collette. Number one is, do you have cirrhosis? If the answer is no, you can actually get even a higher dose. So, for example, we in the States recommend 2,000 milligrams a day if you have liver disease, and if you don't, you can take a little bit more. Again, we will advise not drinking alcohol because the interaction with alcohol can actually potentiate the side effects of these medications. But again, there is no problems and there is no significant side effects in someone with PBC with no underlying liver disease to take Tylenol, paracetamol, acetaminophen as, for pain or any other conditions.
Mm-hmm. And it's over a 24-hour period and not in a morning till night. And I think that's where people get a bit befuddled.
That's correct. I mean, again, it's every 8 hours. Sometimes if you're very uncomfortable, maybe every 6. But again, you're right, Collette. We will not ask them to take more than 2,000 milligrams in a 24-hour span.
Yeah, and that's the thing that it says a day on the box, and I always like to clarify that. And to this person as well, I don't know if that sorts out your pain, then brilliant, excellent. But if it doesn't, and you feel you do need some more, do feel free to come back in and ask what would be safer, because some are more safe than others, if you know what I mean. So the next one, may I ask about bruising? Mine is terrible at the moment. I have PBC and AIH, so it's obviously the crossover. My latest consultant says nothing is liver related and my blood tests are good. Can you suggest what could be causing the bruising? I'd be curious that there are particular blood tests that maybe you could tell us about them so she can check that she is getting the right blood test. Alan, please.
Sure. I mean, I think, one of the key things is to, in someone who has bruising, look at the clotting disorders. And again, patients with autoimmune hepatitis and PBC overlap, as you mentioned, they are at risk of actually progression to cirrhosis. And people with liver disease, they have, as a consequence, the liver is in charge of producing the clotting factors. Mm-hmm. So some of them, they can present with easy bruising, but I would just advise going to the general practitioner or primary care to get checked for the liver test, and also platelet count. It's an important one, and also the clotting factors, because not only liver disease, it could be Ali or something different, but in someone with an underlying liver condition, you really want to make sure they don't have cirrhosis as a consequence of that.
What other conditions can cause bruising? I mean, anemia perhaps, or thyroid, I don't know.
The answer to that question, Collette, is no. But for example, someone with cholestatic liver disease, so PBC can actually predispose you to have a vitamin K deficiency. So remember, the way we absorb the vitamins is we need the bile acids. And if you do have PBC, you don't produce those bile acids, so you don't absorb the vitamin K. So you can actually present with easy bruising. So sometimes this is very easy to correct. You treat the PBC, the bruising goes away. But sometimes we know malnutrition, or someone who's not eating enough, can present with easy bruising as a consequence of a vitamin K deficiency. So yes, you're right. There's different reasons why people can present with easy bruising. But again, in someone who already has an underlying or two underlying liver conditions, want to make sure they don't have either cirrhosis or a vitamin K deficiency.
Well, what substances contain vitamin K? So I'm not very good about vitamins. Are they food substances?
I would say any green, vegetables.
All right. Okay. Yeah.
Again, when someone has cholestatic liver disease, PBC is a cholestatic liver disease, and they're not able to absorb what's called fat-soluble vitamins, then they can present that way. So not only vitamin K, they can present with vitamin D deficiency. So this is one of the reasons people with PBC develop osteoporosis or develop vitamin A deficiency, vitamin E deficiency. So there is something that, as clinicians, we will check on when they present to us just to make sure they don't need that. And if they do, then we will either supplement them with vitamin K, either by mouth or IV or intramuscular, or we will treat the disease so we can actually look at the progression, make sure that their vitamin K deficiency goes away. If that's not the case, then sometimes we have to look further for, clotting, disorders, which are very unusual. But again, it's a pretty big workup. But again, just a general practitioner or primary care doctor, setting the kind of liver test, platelet count, and clotting disorders, they can actually find out if they do have underlying liver disease.
Yeah, that's really helpful, and it's good to know that there's not just liver disease, that there's other causes for it, which that might not be serious at all. But yeah, so any more questions from that person, then please do come back. Okay, we're going to the next one, and the background is I started Urso a month ago. I weigh 70 kilograms and take 1,050 milligrams a day. This was described in 150 milligram tablets, so I'm taking 7 tablets a day, 2 at breakfast, 3 at lunch, and 2 in the evening. I've started to feel nauseous. I see that based on the dosage, my optimum dose falls between 910 and 1,050 milligrams a day. Could I take Urso twice daily and ask to be given 500 milligram tablets to support this? And can I take the entire dose before going to bed?
Great question. So I would say number one is the optimal dose of patients with PBC, as everyone is aware, is 13 to 15 milligrams per kilogram divided in 2 to 3 doses. But as this patient is mentioning, I do have some patients saying it's inconvenient to take it 3 times a day, 2 times a day. So as long as they take it every day, I'm actually okay with that. So actually I tell patients, like, you're too busy, take it everything in the morning and you're all set.
Yeah.
So some side effects of urso can be what's called gastrointestinal distress. So some of patients will develop some crampy abdominal pain, nausea, vomiting. So those patients, yes, maybe could be the dose a little bit higher, but also we want to look there's something else happening. And if you really confirm that you are not able to tolerate because of the nausea and the vomiting, really stepping back, cutting the dose and start kind of escalating the dose is the way to go to see if actually patients will do better with the urso.
That's really interesting. I was also going to say there are to this person that in the UK, I don't even have them over there, but we do have 500 milligrams. But a pharmacist told James Newberger and I some years ago that sometimes it can be the urso that you're taking. Now, the most common urso in the UK is this. It's urso falk, Falk, and these are the people that make them in 500s. They also do 250 milligram, the capsules. But what I would say as well, what we were told by a pharmacist, that because these people were the first people to have a license in this country, the other people will make it a generic type of urso, and the casing, the capsule, could have quite different components in it from what's in here. So it could well be, Alan is coming and going, it could well be that it's not the urso itself, but it's the capsule, whatever chemicals are in it. So quite reasonable to try another brand. And I'm hoping you're agreeing with it. I'm not a doctor, I'm an accountant. And what makes me think they're not taking urso is 150 milligrams, and urso Falk don't do 150. So would you agree with that, Alan, that maybe trying a different, going to the original people who have had this nailed for many years?
Yes, and I agree. And in the US, Collette, we do have the option. We have a 250, we have a 300, and a 500. But again, what he's just saying is we can basically back off, go with a lower dose, and try to kind of go up in the dose to tolerate it better. But yes, I agree. Again, I think in the States also is insurance driven. Sometimes insurance will pay 500 compared to the 250, the 300 because it's a little more expensive. Also, we're going to have to deal with insurances, but yes, I agree with you. Changing the dose, lowering the dose, and see if that I can make it the dose a little more tolerable. That would be really ideal because, as everyone knows, we need to try to get patients to take urso because it is kind of the key treatment for PBC.
Yeah, absolutely, and you need to take it. But I've been taking mine in all of my dose for so many years. I can't count how many now. And I take my breakfast, take them all together, boom. And it's as you say that you can forget about everything for the day. But if you are having a wee bit nausea, just figure it yourself. Have a wee play around and see if you can maybe get your hands on the Falk as well. And let us know. And if there's any issues, do come back. We're always happy to answer questions.
And then don't forget, Collette, to get, to your prescriber because, not only urso, there could be other things happening, I would say, basically goes with other things. I just, do we have to get an endoscopy? Do we have to get an ultrasound? I mean, there's other things happening, so we don't have to blame it always on the urso. But again, if you rule everything out, then yes, we would just try to see if we can change the dose and make it easier for the patient.
You raise a very good point there, Alan, because, and we do talk about this quite a lot, just because we've got PBC, it doesn't mean to say we won't get other things. And there could be minor things from, gastroenteritis, food poisoning, to lack of vitamin K, to thyroid disease, to whatever. So I would say to people, if there's any change, whatever the change is, always report it and let your doctor decide what tests, if any, need doing further, or what might be going on. Always check in change, I think that's fair to say, Alan. I'm saying it, but you would agree with that, yeah. So, okay, we move on. I've been taking Ursula now for 6 months, okay? I still got a pain almost daily in my liver area. Sometimes it's a sharp stab that makes me jump, and other times it's a dull ache. When it happens, does this, oh, bless her, bless him, her, does it mean my liver is getting worse?
So this is a great question, and I always tell my patients that the liver does not hurt. So, you know, when someone comes with PBC and they have an elevation of the alkaline phosphatase, we find out that they have this because someone checked their blood tests. So we don't actually see them because of pain. Yeah. So again, this is just going back to, we should rule all the things, and the stone, that would be a big one. Other issues that can cause pain, the muscular pain, rib pain, all those things need to be assessed before we really blame it on, the liver's getting worse. But again, the answer to those questions are, pain does not correlate with getting better or getting worse in patients with PBC.
Yeah. And also, I mean, as you said, the pain, the liver doesn't hurt. It's got a capsule around it, hasn't it? A sort of membrane. And it's the membrane, is my understanding, that holds all the sensitive sinews and nerves and things. So the liver itself is not hurting. But as Alan was alluding to, it could be gallstones or any of those things, but always have it investigated. And this is my liver getting worse. It's also worth saying as well, and this came out in research many years ago, that the severity of your symptoms do not correlate to where you are in the disease. So some people can be very, very, very tired and think, oh, my illness is getting bad. And it's not. These two just don't walk hand in hand, do they, Alan?
Correct. Again, I've had people, again, as you complain, severe fatigue, and you check your liver tests, they're almost normal, Yeah. But I have patients who really feel nothing, and their bilirubin is up, they're really kind of very close to being sent to a transplant evaluation. So again, you're right. For example, the itching correlates more with the elevation of the alkaline phosphatase, but again, not always. I've had patients who have really itching, they really can just go crazy with their skin, and then, phosphatase is 150, not even really high. So again, you're right, Collette, but again, not everyone who is having severe symptoms actually have a bad disease. So some problem with PBC is not all the symptoms correlate with the blood test. So this is why in the PBC world, we have sometimes medications to treat the disease, and we have medications to treat the actually symptoms. So yes, it is very important to kind of tell your physician, your hepatologist, because we are basically just sometimes are blinded to get your alk phos better, but we forget about all the symptoms, which is a quality of life. So we want to make sure that both of them get treated in an appropriate way.
It's an interesting area, and I would go on to say, and I know in this country, and I'm sure it happens in the States, that if the quality of life is so poor, for example, with itch, now, and some people, not many, thankfully, have a terrible time with the itch that is just untreatable. And if the quality of life is so poor, they will look to transplant that patient. Now, one of our volunteers in Scotland, actually, but she's a very close volunteer to the foundation, very dear to her heart, this girl. And her itch was so bad that she went on to, she agreed to have a liver transplant. And her liver they took out, you could barely see any disease. You could barely see any PBC. Absolutely fascinating.
Yeah, and again, I think, intractable pruritus, itching, is an indication for liver transplant in patients with PBC. The problem is, in the transplant world, we, use the MELD sodium, the MELD score as a kind of a score to get you up there in the transplant list. So unless you're really, really sick from your liver disease, then your name doesn't transplant list unless you have a living donor. But again, let's just before go crazy about transplant, we are getting a lot of new medications. Now there are the PPAR deltas agonists, they're treating itch, the itch pretty well. There's the IBATs inhibitors. New medications are coming out that they're really, really good with the itch. So even the fibrates, again, bezafibrate in Europe, I think bezafibrate will come to the States soon. So again, we are having a new regimen of medications that will be really, really good treating itching. So hopefully, those patients don't have to wait till transplant to improve their quality of life.
Absolutely. And so everybody out there, as you know, I'm always annoying you to say fill in our questionnaires, our surveys, because it's pharma And researchers, people like Alan and David Jones, they come and ask us, they want information. And so the more you give, the better it's going to be for everybody. So, and thank you for everybody that fills in the survey. I make sure I fill mine in right away. So otherwise I forget, I get brain fog. So I hope that's answered your question. So next one, lately my hands and wrists are really hurting even when I'm not using them. I also have aching arms, but my hands are actually worse. Is this a symptom of PBC?
So I would say the answer is no. So PBC can give you bone pain when people have severe osteoporosis. But again, PBC is an autoimmune condition. So you can have only underlying autoimmune conditions like rheumatoid arthritis or lupus. So usually this is the type of questions that I ask to my patients. Is it stiffness or is it pain? And I usually, what I'll do is I'll send them to the rheumatologist to make sure they get an evaluation about this. So is it PBC? The answer is no. But again, remember, PBC puts you at risk for other autoimmune conditions. So we'll look for other things like, thyroid disease, rheumatoid arthritis, because they go along with PBC.
I think as well, it's worth noting again to this person, and I'm really sorry you're having this kind of pain. It must be awful for you. We need our hands, don't we? We use them all the time. Is that please do go back to your GP or your doctor, whoever, and ask about this. And as Alan says, there could be other blood tests. I know there's long queues for rheumatology, but that doesn't stop your doctor, your GP, from carrying out. He'll know what she will know what blood tests to carry out. So, and if we can help further, do give me a ring, but always mention it. There's a lot of this, Alan, that I always feel that some people are very reticent to go to their doctor. I've got PBC now, and they feel I've got to go away and live with it and get on with it. And I'm encouraging people, no, look, doctors aren't ogres. We think doctors are lovely. Gone are the days 30 years ago when the doctor was boss. It's a partnership now, isn't it, with your patient?
Yeah, no, and again, you need to advocate for yourself as a patient too. So again, I'm a liver specialist, and again, usually I'm trying to focus, and usually I like PBC, so I usually focus on PBC. But I think it's important to understand that, all those other things go with PBC. For example, dry eyes, dry mouth, Sjogren's disease can actually give you joint aches, joint pains, all of those things. So what I do ask my patient is just write it down. It's like coming and tell me all your questions that you have, all your symptoms that you have. So we can spend some time and tell you this is related or not. And if you need some other evaluation, related to us, so like in other autoimmune conditions. But again, your PBC questionnaire is, you always ask about fatigue, you always ask about itching, you always ask about joint ache, joint pains, diarrhea. All of those symptoms are part of the kind of the PBC spectrum. So make sure that you talk to your provider or your physician about all the symptoms, because they could be related.
Yeah. Excellent. Okay, so the next question. I have issues with vitamins. Always seem to be missing iron, B and D vitamins. Also L-serine and NEC. Is this due to PBC? Is it okay to take these vitamins all the time? I'm a wee bit concerned here. They've said iron. Iron's not really a vitamin, is it? But vitamin B and D, I mean, is it? I don't know. Vitamin B12 is another story. If it is, I don't know.
Right. So vitamin B12 is, and again, it could be a part of an autoimmune spectrum. So B12 could be an autoimmune condition. So again, it goes with the PBC kind of spectrum. So we'll actually ask your physician, general practitioner, to look for, anemia, like autoimmune or aplastic anemia. They're related to the PBC. In the sense of vitamins, the other vitamins, so vitamin D, when we start talking about patients with cholestatic liver disease, they don't absorb liposoluble vitamins. So vitamin D is a big one. So yes, it could be related to PBC. And the other vitamins, so vitamin C is really not related to PBC, but if you want to take vitamin C, I would advise taking it. Again, you want to be careful because excessive vitamin C can actually develop and can actually cause kidney stones. But again, I don't know all clinical scenarios, but again, just be careful because all those vitamins, in an elevated dose can actually be harmful. Same as a vitamin D, same as a vitamin K. So again, it's an assessment of a condition. So if you do have a diagnosis of PBC, on our first encounter, we do actually send for the clotting disorders, the vitamin D, all those things, and we will replete them if you need them.
And the missing iron, they always seem to be missing iron.
So that, for example, celiac disease is of someone who goes with PBC, and that could be a common cause of someone having iron deficiency. So again, this is part of the autoimmune spectrum of PBC. Make sure that the physician looks for celiac disease. But if there's no celiac disease, make sure there is no like slow ooze from the intestinal tract, such as having a bleeding and needing an endoscopy and a colonoscopy. Someone who's 45 or older with iron deficiency, we'll not make sure they rule out other things like colon cancer or other things. So there's all those things that need to be assessed based on the vitamin deficiencies.
My dog has a deficiency of vitamin B12, believe it or not, just to get injections every so often. But the other thing I would say that is common to have a vitamin D deficiency in the northern hemisphere as well. We've got some sunlight out there, but there's no heat in it, Alan, I can assure you. Okay. So I have PBC and I'm currently suffering from a bad back. Oh, I'm really sorry. I've been recommended to take ibuprofen, which is an anti-inflammatory, but I also hear that I should avoid this medication. Is ibuprofen safe to take when you have PBC? If not, is there an alternative that I could take?
So I think the big question is, number one, does that patient have cirrhosis? If the patient has cirrhosis, I would recommend staying away completely from NSAIDs, we call them, because they can cause kidney injury, bad gastrointestinal bleeding, and if they have varices, they can cause a major variceal bleed. If they don't have any liver disorders or cirrhosis, I think it should be fine. Again, we're going to have to make sure they don't take aspirin because, again, the older you get, taking concomitant aspirin with an anti-inflammatory plus, I don't know, some patients taking prednisone, they puts you at risk for bleeding from your gastrointestinal tract too. So again, talking to your, PCP or your GP to make sure that this is safe for you to PBC perspective. If you don't have cirrhosis, it should be okay.
Yeah. I mean, and some pills are more effective than others. But again, you can always phone in and we can have a chat about it. But if you wanted more specific information, it would all depend on the pain as well, wouldn't it, really? So a bit more info would be, just be careful anyway. But it's a good point. Do you have cirrhosis or not? Okay, so next question. Have you heard about SAM-E for liver repair? SAM-E.
I have not heard anything. I don't know.
No, I haven't. Whoever's asked that question, I don't know if this is a supplement, something you buy in a health food store, but maybe you could come in with a bit more information on that one. So my liver function tests are really good after 22 years on Urso. No real problems. Excellent. I'm very well for my age, 68, except my cholesterol is consistently high. I eat a vegan diet, no animal fats with mostly organic plant diet, so it can't be from my diet. I don't really want to take statins, but my GP is worried about me. My blood pressure has always been good. I don't drink, I don't smoke. No heart problems in the family, but my mother, who was a seriously heavy smoker with high blood pressure, had a stroke in her 70s. Do you have any idea what could be causing the high cholesterol? It's a great question.
So, I think this is a big genetic condition, Again, if you are really good with a diet, I would just say this, you can blame it on their genes. Statins are great medications. It's safe in patients with liver disease, but, in her case, if she doesn't have cirrhosis, even better. She has normal liver tests, so they can watch it. So sometimes elevated cholesterol is associated with the PBC, and the reason why is the way we metabolize, the way we actually digest cholesterol, we use the bile acids to basically put them up and then process in the livers. And when someone has a pretty bad liver, their cholesterol goes up. But the difference between a PBC patient, their cholesterol, their bad cholesterol, their LDL goes up, but their good cholesterol also really goes up, the HDL. So when you look at studies, patients with PBC are not at increased risk of heart attacks. But if you throw in the genes, the bad, genetic predisposition. So I would say I start statins. Actually, we did a study time ago, and then we did find that it's safe to take statins in patients with PBC, and it's actually safe to take statins in patients with liver disease. So if you do need a statin based on all the current scores that we have available and your GP thinks is good for you, it is safe for you to take it without any major side effects from your livers.
It would be a good idea for this person if they maybe got the numbers behind how much of the high cholesterol, the good cholesterol, because it could well be it's artificially high if it's not been broken down. We've got a message from the States on the screen. Good morning, Collette and Dr. Bonda from Mona in the States. Good morning, Mona. So, yeah, and it's fantastic. She's 68, she's healthy, she's doing well. This is good. But she raised the point here, not about herself, about her mother. I'm just going to mention this because it came up a few weeks ago, and we're going to cover it in Bare Facts this time, which should be on everybody's doorstep shortly, is smoking. Now, we all know that smoking is bad for us, but the research that's coming out of late is that smoking is a real baddie with PBC, and that Professor Newberger was saying, Alan, it could quicken the progression of PBC. Have you heard this too?
Yes, or yes. It's like I think there's more data coming out, but I just want to kind of go back to the cholesterol and PBC. It's like right now is, I would say 10, 15 years ago, we were looking at the LDL numbers and the HDL numbers, and we were actually trying to aim a lower number being better. And now we have different scores. So for example, in the States, it's called the ABCD, like the cardiovascular assessment score. And it actually puts, you can Google it, and then you actually put your age, if you have high blood pressure, your cholesterol, and that will give you a percentage of your risk. And if your risk is above 7%, then you qualify to get a statin. If it's below, then we don't. So again, it's not like really like 10, 15 years ago. If you have diabetes, it's a different perspective. Again, I have to just take the whole patient and see what are all the medical history before I say, yes, it's indicated, no, it's not indicated. But I gotta reinforce, Collette, that it is safe to use statins in PBC. It's safe to use statins in patients with underlying liver disease. So sometimes we need to cut the dose, but we know that statins save lives. And again, if there's no heart, there really is no liver. So we really need to protect the heart as much as possible. So the heart takes precedent from the liver. And again, I've seen a million people taking statins. We don't see a lot of liver toxicity. It is reported. We do follow them. We do want to check for them. But again, want to make sure the patients feel that there is safe, it's a safe drug to take. Just to do that.
Yeah, well, that's a very, very good point. Well made, Alan, and I hope that is taken on board. And I think, to be fair, patients with PBC, we do kind of feel, oh, goodness, should we take this and should we be taking that? And some drugs are more harmful than others, but it's great that we can come in and you can get the information here on webinars like this. So thank you, Alan, that really well made point. So, is esophageal, I don't think I could even spell that, Alan. Is esophageal dysmotility common with PBC? I was diagnosed with achalasia, achalasia, achalasia. But forgive me, everybody, as I say, I'm not a medic. And my daughter, who also has PBC, has experienced swallowing difficulties now too. That's an interesting one.
So no, they're not associated. They're two completely different disorders. There are certain patients with PBC, they can actually have scleroderma, another autoimmune condition. They can have an esophageal dysmotility, means that it doesn't move well. So everyone knows the gastrointestinal tract has muscles and the muscle needs to work. So you can actually push the foot down and go all the way down to the intestines. And people who don't and are not able to move the muscles, then they have a dysmotility. And dysmotility can have a different variety of reasons. So their scleroderma can cause the opposite of achalasia, well, the esophagus doesn't move. And in the segment of achalasia, basically you have in the center at the end of the esophagus, basically just the pressure is really high and then there's nothing able to come down to the stomach. But the answer to that question, they're not associated to PBC. That's a completely two different things.
Wow, interesting. I must admit, both are unknown to me.
Yeah.
Okay. Right. I have PBC with little or no cirrhosis. I have an eczema flare-up, or eczema, you might call it, flare-up this week. I felt exhausted and weak, voice, sore throat so much I cannot work. I also have some skin infection, which the GP is treating. Am I more susceptible to eczema or eczema or other skin conditions? I'm waiting as a long NHS list for 1 year and counting for a dermatology appointment. And one question I have is, can I look at biologics to treat my skin issues?
Tough question to ask. Number one is, I don't know if it's.
Oh, Alan's frozen. Alan's frozen. He might pop out and come back in again. I would say to this person, I'm delighted that you're being treated for the infection in your skin, because it's quite common with people to have eczema or psoriasis, for the skin to become infected. So keep an eye on it, and it's good it's being treated. Sorry, Alan, you were saying. You still let know. Wow. Don't know what's going on here. Are you there? Yoo-hoo. I don't know what happened.
Hear me?
Yeah, I can hear you.
Okay.
Yeah. Do you call
Can
it
you hear me?
eczema or eczema? Yes. Can you hear me? Eczema
I
and
can hear you. So just going back to that dermatology and that eczema. So again, PBC is not related to. I'm sure there's some skin conditions related to PBC. But again, eczema is a very common condition. Biologics, I think you need to be assessed with a GP and also the liver doctor to make sure they're safe because of the liver cirrhosis, if that patient has cirrhosis. But I think I would leave it up to someone needs to really look into the medical history and make sure that it's safe. I cannot give a recommendation like that on a webinar.
Mm-hmm. But what I was saying when you were blanked out there, that I've known various people have, psoriasis of the skin, and it's quite common, with a constant itching for it to become infected. And not everybody's aware that it is. So if it's particularly painful or bad, do get it looked at. And the nurse will look at it. And I think, I'm always saying this, two of the most underused medical disciplines in this country are pharmacists and physiotherapists. So do have a pharmacist have a look, and they would quickly be able to tell you about it. But it's very unpleasant. That's for sure. I don't know if this is a question. Amino acids apparently help with fatigue associated with PBC.
I don't know any of those. I don't know any data that shows amino acids will help with PBC. So again,
what are amino acids?
I would say supplements. People have to be really careful with supplements these days. Going to the GNC, all those, over the counter, because what we've seen in studies, actually more in the US, that most of those over the counter supplements, they're not what they actually say they come in the bottle. Mm-hmm. And we've seen a lot of people having a drug liver toxicity, needing liver transplants, or really having bad liver toxicity from those things. So I would just stay away from them. And I think, Collette, we have mentioned it before in webinars, the most important thing, the things that works the most for fatigue, it's exercise.
100%, yeah.
I would say, and I would advise to patients with PBC, just reach out to your GP, reach out to your hepatologist, because taking supplements puts you at risk for having other bad conditions.
One of the nurses at the local, I live about a mile from the only transplant centre in Scotland, and it's one of the 7 UK, and one of the clinical nurse practitioners was telling me that somebody was taken in as an emergency. They'd taken something from a health food store, and it was meant to boost your immune system. They didn't have PBC, they didn't have any kind of liver disease, and they needed a liver transplant. So we get asked quite a lot, Alan, about supplements and these things that you can buy over the counter. I suspect more available in the States than they probably are here. You've got to be careful. And I don't know of any doctor that will comment on them, because they haven't been tested the way every compound that you use and prescribe for your patients is all gone through rigorous testing and legal hoops. And so these things, and this is a problem, isn't it, in the health food stores and such likes, you don't know what's in these things.
Right. And again, we have them available through Amazon. I mean, you name it, how easy you will have access to supplements. And again, I want to reinforce and saying again that it's just, they could be so toxic to your liver, needing a liver transplant. So there's not a single hepatologist that will advise taking a supplement with patients with PBC. We have a lot of medications available. We have a lot of clinical trials, but none of us will prescribe a supplement for this condition, not even for fatigue, not even for pruritus. We have a really good regimen of medications, even a regimen of exercise or regimens to treat patients with PBC. I know sometimes they're not as effective as patients will think they need for their care. But again, we would actually recommend staying away from supplements as much as possible.
Mm-hmm. Mm-hmm. There's something that, thank you. So we've not got any questions at the moment, anybody, but I want to speak to Alan about something. It was something you mentioned last time. If you've got any more questions, bring them in. If not, I'm going to be picking his brains now, because we don't often get time to do that. So when we were here last time, you spoke about in your clinic in the States, if anybody has PBC, then you get daughters and etc. tested. And on the back of that, I had a phone call from somebody terribly worried. She is a worrier. She's a terrible worrier. It's just the way she is. And she was worrying sick about her 18-year-old daughter. And I said, well, in this country, they're not tested unless they show symptoms, etc. So I gave this lady reassurance. Her daughter's quite healthy. She's athletic, no symptoms whatsoever. So I was able to reassure her, but encouraged her to speak to her liver specialist herself on a one-on-one basis. But so on that, and the fact that you do test in America. So what are the percentages? I was led to understand that there's just a small percentage of people with PBC will have an immediate family member who also has PBC. Do you want to tell us a bit about that?
Yeah, so again, it's there's a genetic predisposition. So, and again, as a disease, it goes in female predominant. So what I tell my patients, if you're a female in your 40s, 50s, and you have PBC, I would advise testing all the females. If you have a daughter, you have a sister, you have a mom, to test them with an anti-mitochondrial antibody. So there's two schools of thoughts in this, Collette. And again, I don't think there's a wrong or right answer. So what I do
it's interesting to hear your points.
I will say if they're positive AMA, most of those patients will have PBC, will develop PBC, either symptoms or abnormal liver tests in the future. So either you can watch them closely, follow their liver test once a week, once a year, twice a year, making sure that everything stays okay. Yeah. Or some people would advocate, say, well, you have a positive AMA, should we start ursodiol, which is a really not a lot of, it's a medication that has not a lot of side effects. So actually I'm inclined sometimes to put those patients in ursodiol and then follow them. Because we know there's been some studies that people with a positive AMA, again, you will develop symptoms, histology, which is basically findings in the liver biopsies that are consistent with PBC. So we do genetic counseling because I know, again, for example, in the UK, this affects your life insurance. I know in the US, it does affect your life insurance, and it's a big thing. Yeah. But again, I have to kind of disclose this information with the patient and say, this is the options. Either we can monitor you once or twice a year, or basically we can test you and we can put you on a medication. And if you look at globally, I think there's really different school of thoughts and people do a little different things. So, and again, there's no right or wrong answers in this perspective, Collette. So what I'll do is I'll do what the patient tells me. Again, if they tell me I'm going through life insurance, maybe I really don't want to kind of really, of you getting life insurance. But again, maybe after they get the life insurance, we can maybe readdress. It's a different perspective. But again, a positive AMA really, it's such a very specific test that, so that, if you do have it positive, it's very likely that you will develop PBC.
So what sort of percentages would you say, what is the percentage of somebody having a close family relative with PBC? I always thought it was where it's here, 5%. But I was discussing this with Robert on the back of our chat last time, and he said, no, he thinks it's higher, as you're indicating.
Yes, I mean, there's some genetic studies. I think Somi also in California did some studies, and they looked at 20%, incidence of positive PBC, AMA in someone who has PBC. Do you really say those patients have PBC? Really, they're in increased risk. But I would say if you are a female and you have someone who is, in your direct and your first generation, then there's a 20% chance that you will get PBC. So it actually is pretty high. So this is why I really do disclose to that patients. Again, if you see young people in their 30s and 40s that have young kids, again, I wait, as you were saying, maybe they're 18, 80, age 20 until we start testing them, because there's really nothing to do when they're really, really young, unless they develop other autoimmune conditions. Then we start looking for other things.
Mm-hmm. Now, there's 2 questions I've got for you on this. This is fascinating. Hope you don't mind. So, what's the youngest PBC patient you've seen?
I saw a 19-year-old.
Wow. Oh, that's quite distressing, really, isn't it? Yeah. Although I'm going to send you my front page, my retiral page, a bit of a story to the foundation. I'll send it after this broadcast today. I was 17 when I had the symptoms. I wasn't diagnosed. I was 37. I was diagnosed as being a hypochondriac, but hey, that's not, that wasn't unusual in those days. But Professor Newberger once said to me, that is not unusual for people to get symptoms, but it's much later when they're diagnosed.
And I think, Collette, I mean, not that you, like, and remember, 20, 30 years ago, we didn't have all the, we didn't know everything about the things that we know about PBC now.
Yeah.
So, again, for example, a 17-year-old, 19-year-old tells me he has fatigue. Of course, there will be a different million reasons, or has itching, there's a different million reasons. But again, we have to rule them out. You're a female, you have pruritus, you have itching, you have fatigue. Those some of the things that we need to just keep in the back of our mind is like, does this patient have PBC?
Mm-hmm. 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 And I've got another question come in, but I want to ask you something else. My questions, just for the bigger picture, so people can, these are things I get asked on the telephone. Now, I'm one of 7 children, 5 girls and 2 boys, and I'm the only one with PBC. I'm the nicest. Obviously, nice people get PBC, right? And I've got lots of Irish cousins. And this is the thing you mentioned, celiac disease. It seems to be of Celtic origin. But my cousins, not so much my sisters, my cousins have celiac, vitamin B12 deficiency, scleroderma, da-di-da. And this seems to be quite common, Alan, is not necessarily PBC in the big family circuit, but other autoimmune conditions, thyroid, whatever. What would you say to that? Is this what you experience?
It is. And again, if you look at that, what is the percentage of people, if you have a patient with PBC, so the most common autoimmune condition that goes with along is Sjogren's. So 30 to 40% of patients with PBC develop Sjogren's. That's dry eyes, dry mouth. The next one is thyroid disease. So it's very common.
Oh, he's gone again. Well, this is absolutely fascinating to get to know this. I think he'll come back in again. We've got another question here. So, and I'm sure many of you can relate to what Alan's saying, that you've got family members. Here you are. We've always got a better signal here in the States. I'm saying this is fascinating what you're saying about families. We've got another question in, but I want to hear more.
Can you hear me now? Sorry.
Yeah. Yes, I'm saying it's fascinating what you're saying about
and again, it is a spectrum. And if you look at, when we look at where PBC comes from, it's not only a genetic disease. It's, I would say, a multifactorial. So you have a genetic predisposition, plus you have a trigger. We don't know how this plays along, and then slowly you develop PBC. But again, the trigger and the genetic predisposition, if you look at the kind of we call the HLA, the genetic part of this, it comes very similar for rheumatoid arthritis, Sjogren's disease. So all the genes are from the same area. So it is not unheard of that, you come from a family, you have celiac disease, you have Sjogren's, you have scleroderma, but you have PBC. So that's actually, you see that in the patients who come with me with PBC, people have Crohn's disease, or people have rheumatoid arthritis. So it is, once you develop an autoimmune condition, you are at risk of developing another one. So that's why we have to look for them. So, when we first started this webinar, a patient said, I have wrist pains, then, we have to look into this, make sure they don't have an autoimmune condition.
Yeah, that's interesting, because I was diagnosed with Sjogren's before I was diagnosed with PBC. But what I have in my small experience, I used to be asked to speak at the Sjogren's Society in various parts around the UK. And I would go just because I started the charity as they had then. And they didn't realize that I had Sjogren's too. They'd be quite surprised. But what I found that people who had Sjogren's and nothing else, not PBC, they did seem to have Sjogren's worse. joints and needing to wear splints and all sorts of things. That's on an anecdotal observation. Most people with PBC that I speak with, it's eyes and mouth. But you have a very famous American, one of the Williams sisters have got Sjogren's, haven't they?
Venus Williams.
Yeah.
Mm-hmm.
Right, this question, here we go. It's our last question, Alan. You've done fantastic today with loads of information. You mentioned how bad smoking is for PBC. I gave up about 25 years ago. If a patient spends a lot of time with a smoker, is that also a concern? It's a great question.
Great question. The answer is, so we know, and I think we know people who have PBC who smoke progress, meaning they have no scarring, they keep smoking and develop scarring and develop cirrhosis. What happened if you stop smoking in your PBC? So I don't know if smoking is a trigger. So there's been some studies looking at smoking being the trigger to diagnose PBC. So for example, there's some interesting studies about being close to trash areas in New York City. And again, I think I mentioned before, in the UK, close to Newcastle, like factories and stuff like that. So people who are close to those type of toxic environments, they're more representative of PBC. So if you look at the New York area, people who actually live close to the trash areas, they actually develop more PBC than people who didn't live in close to the trash areas and smoking areas. Is that a trigger? No one knows. But again, once you quit smoking, I think it's a great thing to do, but nothing to do after, 25 years later, I will not say that smoking has anything to do with the PBC.
I've got another question coming. I would say to anybody out there who smokes, and I heard James Newberg, I gave my telling off for saying it's really, really difficult to stop smoking. And then, it's not, because I'm an ex-smoker and I was a heavy smoker a million years ago. And I would recommend everybody buy the Alan Carr book. He was successful. He got 97% of smokers off the cigarettes. It can be done. Nicotine only takes 3 days to get nicotine out your system, and if you can manage 3 days, you'll manage for the rest of the life. Now, and Chris, my younger son, he will laugh because he gave me the book. I actually ended up meeting Alan Carr. He's passed away now because he was quite old, elderly, but he would give anybody with PBC in the UK free treatment, to stop smoking. So it can be done. And if anybody wants to know, give me a wee ring. But it's a bad year. I remember James Newberger said to me, 1 glass of wine is okay, but 1 cigarette is not. Consider myself told. Right. Would a small amount of testosterone along with estrogel help with fatigue?
Whew. I mean, there is ways to prove that concept, Collette. Again, they are doing.
Oh, we're losing you. I think Alan will come back in again. The wonders of modern science, but we always get there in the end. You're very adept at this, Alan.
Are we back?
You're back. You're here. You're cooking the
classes. I would say there's no studies in PBC and fatigue with hormones, but there are some studies in patients with cirrhosis actually going now as we speak. Patients have testosterone deficiency because the liver, the liver is kind of the organ to produce them.
He'll be back with us shortly, I'm sure. There we go. There we go.
What's going on today?
Yeah.
But I would say I would not recommend using hormone replacement therapy as a treatment of fatigue. Yeah. I don't have any evidence to support that. And again, there is more, there's more side effects, blood clots is the big one, cancer. So I just want to make sure they check with a GP before they actually get into a hormone.
Doubly sure, don't muck about, because it takes many, many years to train a doctor. And so these are the people that, and if they don't know, they know where to find out, they know where to get the information. So Alan, tell me now, are you coming over to EASL to London in June for the, I'll tell them the EASL is a European Association Study of the Liver.
I wish. No, unfortunately not next year. I know you guys are doing something, but I won't be there, but hopefully next year.
Well, I'm doing a symposium. Intercept our organized a symposium with myself with David Jones and some doctors from various parts of Europe. And we're going to be talking, I've got another wee question, and we're going to talk about PBC then and PBC now, which you've alluded to perfectly. So I'll do this question if that's okay, Alan, but I think it's going to be very interesting. Is the perimenopause a trigger for PBC?
Wow, that's a tough question. So I don't have a really good answer for this, Collette. I would say if you look at how we're diagnosing PBC, there's tons of data that we are diagnosing more people in their 50s, 60s these days. Is a perimenopausal menopause time the trigger? We don't know. But we know that we're diagnosing more people 50s, 60s, even 70s. So I can't tell you for sure, Collette, this is it correlates with menopause, unfortunately. So I would say back 20, 30 years ago, if you look at the description of PBC, this is a young female in the 30s, 40s, and 50s with an elevated hot fuzz and itching. In today's age, I would say this is not the common thing. Is that it's still the other conditions, but we see abnormal liver tests for other kind of issues, and we do find a positive AMA, and we have PBC. So I think that's the before, and this is the today. So we have a really different population that's getting diagnosed with PBC, unfortunately.
And younger, but great, because we get people on treatment, because when I was diagnosed there was no ortho. It came quickly afterwards. But that's all our questions. Thank you so much. But Alan, I think that's probably the last time you'll see me on screen, because Robert's coming down. We've got Caroline says, thank you very much, Collette and Dr. Bond, very interesting. He's gorgeous, isn't he? He's lovely, Caroline. Because Robert will be taking over and he'll want to do things in his way, quite rightly. Mona, thanks for another great session, great information. I hope you all have a great day on you, my darling. But I've really enjoyed working with you. Now, I will be in the background, not in the office or not getting involved in decisions or anything, but I will be around, Alan. Oh, you got somebody in the room. I will be around, but I can't thank you enough. It's been a couple of years. You've been really supportive of the foundation, and we're really, really grateful. And it's nice to have, dare to say, a younger doctor as well. But thank you, and I do hope we meet if you come over to the UK, which I'm sure you will. Maybe you'll let me know in advance, and I'll come to London or wherever you are, and we can have a cup of tea.
Thank you, Collette. Thanks for inviting me to be part of this, and whoever takes over, I will continue to be there.
Well, you know Robert of old, and now you know Chris. Now you know Jacqueline. So all I can say to everybody out there, thank you so much for coming in today. And I hope Alan's answered your questions. He's a lot quicker than Dave Jones, which is a winner. We get a lot more in. And thank you for answering my questions, because I get asked a lot of things on the phone as well. So thank you to the team. Linda's in the background. Linda's hammering stuff down the airwaves to me. Thank you, everybody. Alan, all the very, very best, and I hope you stay with the foundation.
Thank you so much, Collette, and enjoy your retirement.
I will do. Thanks, everybody.
Thanks, Alan. Good to see you.
Cheerful. I'm going away now.
All right.
Bye.